One of the most important things for us to remember during Minority Health Month is that not only do we have to look at what happens in the healthcare system, but we have to look at what happens in the rest of people's lives. What's their housing like? What's their access to jobs like? What is their access to food like? Because if we don't look at those things, we will never achieve our goals in equity in health outcomes.
And so when we think about and talk about implicit bias, or we talk about racism, we really have to move away from this kind of individual actor. There are a set of inaction in the face of need, right? Or actions that are biased in their construction have a lot to do, they're primarily systems. So you can replace person A who's black with a white person, you can replace a man with a woman and vice versa. It doesn't really solve the systemic issues. So the systemic issues require a different lens. We have to move our gaze from the individuals towards the system. I think when we do that, we're in a better position to solve these systemic issues. With only 13% of the population, we cannot have black doctors everywhere there are black people. So we have to think about this issue a little bit.
Healthcare's disparities do not lie. And so what we know is that there are undoubtedly healthcare outcomes that affect certain segments of the population and not others. And the issue is that Minority Health Month gives us an opportunity to really put a fine point, a laser focus on what it is that we need to do differently and perhaps more poignantly in order to address those issues, to create a more equitable future for everyone, because everyone deserves to grow up healthy and strong in the state of New Jersey. That gender too is a social determinant of health, and then as we take a look at the impact of race and gender, what we understand firmly is that these women do not decide, I said this to your staff earlier, right? We don't wake up in the morning and decide that we want to have a higher incidence and or mortality rate from breast cancer. That's not what we choose for breakfast. Right? But what we do have is a historic level of distrust with medical institutions, and we have them because they have earned it, quite frankly, right? So when you develop the science of obstetrics and gynecology on the backs of black female slaves, you know, we remember that because we have a very strong oratory history. And yet we have that with institutions who seem not to recall that when they go to teach their clinicians, right? So and their practitioners. So there is this natural inclination to push back against it, the natural strategic tension. That's why I like to say it, because I want to make it a healthy thing.
While domestic violence and sexual violence cross all racial, ethnic, and social lines, it is really critically important that women from marginalized communities, particularly communities of color, began to talk about how domestic and sexual violence impacts them on a daily basis. Not only does the trauma of the initial abuse occur, but we also have to look at the long-term effects that domestic violence and sexual assault has on our community.
What we continue to see is African American women are both more likely to get breast cancer and more likely to die once they get breast cancer. The interesting thing is that 10 years ago, what we used to say was that black women were less likely to get breast cancer and more likely to die. But now it turns out they're more likely, and we think that that probably has to do with obesity. What we know is that African American women die at higher rates from cervical cancer, significantly higher rates actually from cervical cancer. They die from higher rates of colon cancer. They actually don't die at higher rates from lung cancer. Actually, lung cancer deaths are still highest among whites in the state. But if you look at stroke and diabetes and renal disease, African American women are dying at significantly higher rates from all of